Tuberculosis in the eye. An overview. Ocular TB caused by Mycobacterium tuberculosis. It can affect any ocular tissue. Can be direct or secondary infection. Epidemiology of ocular tuberculosis: 0.4 to 9.8% prevalence in India, 1 to 2% of US TB cases. More common in TB-endemic countries. Both adults and children are affected. So let's talk about the pathogenesis and route of ocular infection. It's the most common hematogenous spread from a distant TB site. Direct extension from adjacent tissue is rare. Primary infection via external eye structure. Ocular tissue affected by TB. Any part of the eye, that is a conjunctiva, cornea, sclera, uvea, retina, optic nerve. Categorized as extraocular and intraocular involvement. Clinical manifestation: anterior segment granulomatous anterior uveitis with iris nodule, that is the copae or Busacca. Scleritis and conjunctival nodule possible. Clinical manifestation: posterior segment, posterior uveitis, more common from choroidal tuberculosis, serpiginous like lesion, retinal vasculitis and optic neuritis possible. Other ocular presentation are extraocular like eyelid, lacrimal gland, conjunctival involvement, which are rare, endophthalmitis or panophthalmitis at sight threatening. Common symptom of ocular TB is blurred vision, photophobia, floaters, headache. It may be asymptomatic or mimic other ocular diseases. Diagnostic evaluation: eye examination by slit lamp ophthalmoscopy, fundus evaluation, TB screening, skin test, interferon gamma release assay, imaging, X-ray chest, ocular imaging, diagnostic challenges. Isolation of mycobacterium from the eye is difficult. So diagnosis often based on suggestive findings, systemic TB evidence and treatment response. Differential diagnosis: rule out syphilis, sarcoidosis and other causes of uveitis or scleritis. Ocular TB is a great masquerader. Treatment of ocular TB: standard 6-month multi-drug anti-TB regime. Phase 1, that is the intensive phase, rifampicin, isoniazid, pyrazinamide, ethambutol for 2 months, and phase 2, rifampicin and isoniazid. Sometimes we add ethambutol. Adjuvant therapies: corticosteroid for inflammation control, coordination with infectious disease and ophthalmology specialists. Prognosis: and complication. 92% show ocular inflammation improvement with treatment. The risk of permanent vision loss if untreated or delayed. Some of the anti-TB drugs like ethambutol, isoniazid, and now newly linezolid can cause visual side effects. Prevention and summary. Early recognition and prompt treatment. Crucial. Consider ocular TB in persistent or atypical uveitis, especially in TB-endemic regions. Multidisciplinary management improves outcomes. Thank you.